Good evening, everyone. Thank you again for joining us tonight to discuss the AdMeTech's Prostate Cancer Equity Program. I am Kathy Reddick. I'm president and CEO of Thru Foundation, which is a foundation that gives support to women who are going through breast cancer or those in survivorship. I myself am coming up on 12 years as a survivor of triple negative breast cancer. My dad was a prostate cancer survivor. And when I met Dr. Stern a few years ago, what I found out was that there is a close familial tie in families of prostate and breast cancer. So I got very interested in how to get the word out about prostate cancer. What we have for breast cancer, I think everybody gets the message about that. But prostate cancer is one that is still hard to get men in. So we need the help of women and families to help get the men out. So I'm pleased tonight to host this event. We're going to have some guest speakers to talk about it, and you'll hear from Dr. Stern about the program. We're just waiting for one more person to come on. So actually, Dr. Stern, would you mind giving a brief welcome, or should I have everyone just go around and introduce themselves while we're waiting for Mr. Cox?
Absolutely. Katya, first of all, thank you for your partnership for this event. Thank you for organizing that. It is appreciated and valued. And I very much appreciate everyone's presence here. It's our pleasure to work with you and to get the word out about our prostate cancer program, including equity program that gives men direct access to leading experts in the state. So everyone, welcome to our event.
Thank you. Why don't we start with Dr. Wasson? Would you please just give a brief introduction about yourself?
Sure. Sean Wasson. I'm a urologist at Beth Israel Deaconess Medical Center, and I work primarily in Needham and Milton Hospital. Before joining the Beth Israel Leahy Group in January, I was at Boston Medical Center for the last 5 years. My wife is from Norwood, and we have ties now to the area, and been in sort of this area for for a number of years. Before that, I did fellowship down in Eastern Virginia medical school, where I was in Norfolk residency. I was up in Lebanon, New Hampshire, and then for medical school, I was at Howard University College of Medicine, graduate of 2005. And I'm a urologist, and I primarily do endoscopic work, and a lot of this work kind of deals with prostate cancer, kidney cancer, bladder cancer, amongst other things that I see as a urologist. So I connected with Dr. Stern several months ago, and I've just been happy to be part of these community cancer talks and really raise awareness on prostate cancer and what we can do about it. So thank you so much for the invite today.
Thank you for being with us. Ronald Green, would you please give an introduction of yourself?
Sure. My name is Ron Green. I'm a registered nurse for over 50 years, with my largest bulk of time being spent at Mass General. I retired, I think. I don't think I really retired. I think I retired from Mass General 15 years ago, but I still am involved with a lot of different things, political things in my town, healthcare speaker. I lecture at different groups, especially at men's health things in the church. And I'm married. I have 3 kids, 11 grandchildren, and I don't know what else to say. I just feel like I just keep on going, and I feel lucky to keep going. So, and talk about urology. I just have to tell you, on my resume, I've worked in the emergency department, urology, orthopedics, radiology, and internal medicine, did case management, private case management, and so forth. And the list goes on and on. And just today, I made a phone call to somebody. I spent, I think, like maybe 3.5 hours today connecting with different Black nurses, because I used to be the president of the regional Black nurses. And I said the best way to get to the men is to get to the women who go to the church. And so sure enough, they're going to hook me up. So when they have the Men's Health Day, I can go and speak. So already I have 4 churches.
That's wonderful. And
Yeah.
Ron's is coming on as our clinical coordinator is your title for the Prostate Cancer Equity Program. So we're excited and really pleased to have him come on board to assist with educating the public. Well, our first speaker is still trying to log in, unfortunately, so sorry for the delay on that. Dr. Stern, do you want to get started with your part?
Absolutely. Actually, I would suggest for Sean to go first
Okay.
and do his presentation, and I'll follow up on his presentation.
Okay. So Dr. Wayson is going to speak to us about his perspective on prostate advances in prostate cancer and treatment.
So thank you so much. For this particular talk, no disclosures other than my grandfather, Ernest, as we called him, grew up in Barbados, did have metastatic prostate cancer. And, I wonder if he had access to the, the early diagnosis and treatment that we have. I wonder if things would have been different for him. So it does run in my family. And tonight, I just wanted to go over a few things. Screening, what are their goals when it comes to screening? Who do we screen when? How do we make the diagnosis of prostate cancer? What kind of imaging and biomarkers do we use in this particular diagnosis? And then what are the treatment options for men with locally confined prostate cancer? So kind of a broad overview of prostate cancer, where we've been and kind of where we're going. What is the prostate gland? It's a small little gland that sits tucked in between the bladder and the rectum. It's usually about the size of a walnut, but can be enlarged, can cause a lot of urinary symptoms. It's considered part of the urethra channel. And so as men age, the prostate tends to grow and can compress the urethra and cause a lot of lower urinary tract symptoms. Doesn't necessarily mean that you have prostate cancer, but there is another phenomenon called benign prostatic hyperplasia that we really have to determine the difference between the two. It's a reproductive organ, contributes to semen, and obviously it can get prostate cancer, but 1 in 8 men will be diagnosed with prostate cancer in their lifetime. So it's number one cancer in men. The goal with prostate cancer screening is to maximize detection of what we call intermediate and high-grade cancers. We really want to minimize the detection of non-life-threatening or low-grade cancers, and then decrease the unneeded biopsies and the over-treatment of men with this disease. So the American Urologic Association describes early detection as screening, and it implies detecting disease at an asymptomatic stage, meaning that men really don't have any symptoms. They wouldn't otherwise seek care of a clinician, and really kind of look for early prostate cancer. So if you're under the age of 40, we really don't recommend any screening in this particular age group, so that's good. The panel strongly recommends what we call shared decision-making. So you and your primary care provider discuss the pros and cons of PSA and prostate cancer screening. And so the group that gets the most benefit are in between the ages of 55 and 69. If you're over the age of 70, we don't necessarily recommend routine prostate cancer screening unless you're in great health, and there's a lot of men out there that live well into their 80s and 90s. And so it's not necessarily for everybody, but it's a discussion that you need to have with your primary care provider. If you're in between the ages of, let's say, 41 and 55, I think it's very reasonable to get, at least one PSA test to make sure that it is low. And I would personally advocate getting a baseline PSA at the age of 45. How do we find prostate cancer? Really, we have the PSA, it's just a blood test, and then the digital rectal exam. I still think that the digital rectal exam is valuable. Just for instance, a couple months ago, there was a young man with a normal PSA. We did a rectal exam on him that was clearly abnormal, and we found high-grade disease. So there are certain rare situations where you can have palpable, significant disease with a very low PSA. So I'd always advocate men to advocate for themselves. Hey, doc, are you doing a rectal exam to look for any nodules? Prostate cancer screening is done best in combination. but you really need to do the prostate biopsy to actually make the diagnosis. So I think PSA gets a bad rap. It is really only produced by the prostate, which is good. So if the PSA is high, it means that there is some sort of prostate disease, but it doesn't necessarily mean that you have prostate cancer. So it's very sensitive in that if there's prostate disease, the PSA will be high, but it doesn't necessarily mean that you have prostate cancer. PSA is really one of the first and only first biomarkers that we've kind of used in prostate cancer, and it's really used throughout screening, diagnosis, before treatment, after treatment. This is how we follow patients. So you really have to know your PSA levels. From a urologist perspective, we used to do mass screenings on men, and this has really fallen out of favor. We all know that PSA does have several limitations. You want to do shared decision-making with your primary care provider. Patients that are high risk, so patients that have a, like Kathy mentioned, family history of other malignancies such as breast and ovarian cancer and prostate cancer, really need to be screened very closely. Age and comorbidities, so other medical problems often dictate what we do. Who gets screened dictated by the primary care providers, and then who gets biopsied is often dictated by the urologist. So if the PSA is under 1, that's normal, especially if you have a normal rectal exam. I think that you can extend the PSA screening up to about 2 or even 4 years. If the PSA is in between 1 and 3 with a normal digital rectal exam, we'd recommend screening every year. If the PSA is over 3 or there's a suspicious digital rectal exam, those are the patients that should get referred to a urologist. And then in those situations, we'll consider doing a multiparametric MRI, which is relatively new in the sort of pre-biopsy phase. We would consider doing some adjunctive tests like biomarkers. And then those patients that we have a high suspicion for prostate cancer, they'll get directed for a prostate needle biopsy. For those patients that we have a low suspicion, we would probably just surveil their PSA and do a rectal exam every 6 to 12 months. So most patients will come in, we'll get an assessment of the prostate size, the anatomy. Does it correlate with the PSA? Because we know PSA does increase as the prostate size increases. So we can do a transabdominal ultrasound to figure out the prostate size pretty easily. If we are going to go ahead with the biopsy, it's really done by one of 2 routes, the transperineal or the transrectal route. The transrectal is probably the most common. That's taking the ultrasound probe through the rectum, imaging the prostate, and then taking our samples. We know that it does increase the risk of infectious complications, such as bacteria in the blood. And so I think the latest way to do the biopsy is the transperineal route. And there's a lot of urologists that are kind of moving from one technique to the other. Regardless, we want to get some sample from the prostate. You may hear of this novel technology called micro-ultrasound. We recognize that there's some value with really high definition ultrasound. And with this particular technology, we can get very close imaging of the prostate. And we can actually look for very abnormal lesions that we couldn't necessarily look at on the traditional ultrasound. So this gives us like a high def view based on the ultrasound. The nice thing about it is doesn't cause any radiation. It's you can image these lesions in real time and then target them in real time. So you may hear a little bit more about this micro ultrasound technique. We take 12 samples of the prostate, usually 6 on either side, and will tell us the grade, how aggressive is the prostate cancer, what is the volume, where is the location of the cancer. And then I think to simplify it for our patients, we've come up with the grade grouping. So we kind of know in our heads 1 to 5, 1 being low, 5 being high, just makes it a little bit easier for patients to comprehend. And you really want to know your Gleason score. So that's something that you really should have a very good idea of how many cores were positive, what was the Gleason score, and then for each core, what was the volume, because that really dictates the type of treatment that will be offered. multi-parametric MRI has been around for a number of years. Dr. Sturm was really involved with some of the early work in MRI, and we know that we get phenomenal pictures. I like to get an MRI if I can before a prostate biopsy, looking for abnormal lesions. We're looking for suspicious areas within the prostate that we want to target with the biopsy. And then it can also tell us what are the seminal vesicles, are they involved? Are there lymph nodes that are involved? Is there any disease that looks like it's coming out of the prostate? Are the lymph nodes and bones involved? So we get a lot of information from the MRI. And then there is this scoring system that also goes from 1 to 5. And we're really looking for the PIRADS 4 or 5 lesions. So if you get the MRI report, you want to go over it with your urologist and see, okay, do I have any 4s? Do I have any 5s? Do we want to biopsy these particular areas, doc? And now what we can do is we can take the MRI, fuse it to the ultrasound, and then we can target these lesions very accurately. So we'll do our standard template biopsy, but then we also want to biopsy these PIRADS 4 and 5 lesions. And so now I think the biopsy is a lot more accurate and more meaningful than, let's say, it was in the past. We know that prostate cancer is a very wide spectrum of disease, and this is just one of the guidelines where they show us that there's very low, intermediate, high, and very high risk prostate cancer. So, I have a lot of patients that say, okay, well, my uncle had, prostate cancer and had this particular treatment, but not everyone is the same. So it's just very important to kind of keep this in mind. What are biomarkers? These are urine and blood tests and sometimes tissue tests. And we use these to kind of risk stratify patients, and they're used in all aspects of patient care. So before a biopsy, we can put a patient, let's say low or high risk. We'll sometimes use these after biopsy and even after treatment to really risk stratify patients to have more information than, let's say, the Gleason score alone. We don't use this for everybody, but they can be used in certain select situations. And, I think it's worthwhile for patients to ask, are there any biomarkers in this area that could be useful in my situation? This is just one example of one of the biomarkers that we use, Oncotype DX. And so if I biopsy somebody and I do find a little bit of prostate cancer, I can send it to this company. And what they'll do is they'll examine the actual tissue. And then what they can do from a genetic standpoint is tell us what is the risk that this patient may die within 10 years? What is the risk of metastasis? And if I were to remove the prostate, what is the chance that they would have some of the abnormal features? So you may know or be aware of CT scan. So let's say you have a positive biopsy and we find prostate cancer. We want to know, is it localized or has it spread elsewhere? This is typically combined with a bone scan. And there are limitations for these imaging modalities because they're not very sensitive. It requires a lot of disease for these to be positive. And so there's newer technologies. This is one in particular called PSMA. And it's only secreted really by prostate cancer cells. And what you can do is you can bind a radio tracer to PSMA, and then it lights up in areas where prostate cancer may have spread outside of the prostate. So you may see this particular technology more and more common. It's very sensitive. And in patients who we once thought were candidates for localized disease, now we're finding, well, maybe there was disease outside of the prostate. If someone does have clinically localized disease, then there's really a couple different options that you can do surgery to remove the prostate. Active surveillance is, maybe they don't have a very long life expectancy, or maybe they have low risk disease. We want to keep a very close eye on this particular patient and make sure that it doesn't spread. And then there's radiation options to treat prostate cancer. If a patient is very low risk, so we really try to, put patients on active surveillance. So you're not likely going to die of prostate cancer, but, you're most likely going to die of something else. These are the patients that are great candidates for active surveillance. So we're not going to treat you, and that's going to be okay. For patients with low risk disease, and sometimes this particular area will use biomarkers to say, okay, well, yes, this is a very low risk patient, or they have a low likelihood of dying of prostate cancer. And then we may want to get some further imaging or repeat biopsies down the road. Why would we put someone on active surveillance? The disease is slow growing, the patient may not live that long, and it really avoids the common side effects of surgery and radiation. Can you still get treatment? Absolutely. And we would probably delay treatment until there's evidence that there's been, some progression of disease. Prostate cancer tends to grow pretty slowly. And so this has really been a safe way to kind of monitor prostate cancer in some regard. Those patients that are on active surveillance, they typically will undergo multiple biopsies, and so that can be problematic. There's often a lot of anxiety associated with repeat PSA tests and MRI, and so that's just something to keep in mind for some of these patients. For patients that have intermediate risk disease, and these are the patients that we really can cure. And, we have very effective ways of curing patients with prostate cancer. And radiation is just one of those. It can be external beams, so outside of the body. It can be internal seeds that are placed into the prostate. And then there's different types of radiation that can be done. This is just one type of radiation where we're able to really target, the radiation oncologists are able to target where the prostate is in space and really minimize damage to surrounding structures. I would say that surgery and radiation are essentially equivalent in terms of their cancer control. Brachytherapy is just a term that we use to put radiation seeds into the prostate that over time will kill the prostate cancer, and then the radiation does die out. And then you may hear CyberKnife, which is a different form of radiation, and you can typically give higher doses of radiation in a shorter amount of time to minimize damage to the surrounding structures, like the rectum. We use this technology, spacer, where you can put a gel that's in between the prostate and the rectum to really lift the prostate off the rectum, and it really minimizes damage from the radiation to the rectal wall. And so you may hear spacer a little more common. There's other companies out there, but that's the most common. There are side effects of radiation, fatigue, urinary bowel symptoms, and then erectile dysfunction can occur after radiation. Surgery can be extremely difficult after radiation. And so just keep that in mind. Prostatectomy, that's removing the prostate and the seminal vesicles. This can be done in an open fashion, laparoscopic, or robotic fashion. And I would say that most of the prostates that are removed in this country are typically done in a robotic, minimally invasive fashion with this technology called the Da Vinci surgical system. Pretty much all the major hospitals have this technology here, and it just speeds up recovery for our patients. And so it's not uncommon for patients who have missed major cancer surgery to go home the following day, which is really remarkable. Surgery is about 2 to 4 hours. They spend the night in the hospital, catheter from 1 to 2 weeks, and then they're usually back to work in a couple of weeks. It does take some time for their continence to improve. And then, erectile dysfunction, which can be an issue after the surgery, is highly variable. There's a relatively new technology called HIFU, high intensity focused ultrasound. A lot of research has been done in this in Europe and Canada, and it's FDA approved, and it was FDA approved in 2015. Not many centers that do this, but I think that it's for some select patients with smaller volumes of prostate cancer. So a lot of men will ask, how do I be proactive after a diagnosis of prostate cancer? And Dr. Klotz from the University of Toronto gave us a talk not too long ago. Number one, smoking cessation, and then speak with your physician about the benefits of vitamin D, a low dose statin, and metformin. And I think that there's emerging evidence to show that these could have a positive influence on patients with prostate cancer. So in summary, prostate cancer is very common. Aggressiveness is quite variable. Earlier detection is favorable, and we want to detect cancer early, and then really maximize the detection of the intermediate and high-grade cancers, minimize the detection of non-life-threatening cancers, for which there are many. Imaging and genomics are used to improve our risk stratification, and this has really allowed urologist patients to be more comfortable with active surveillance. So for very low and low-risk disease, consider active surveillance. Intermediate and high-risk disease, surgery or radiation. And then there are other treatments that are becoming a little bit more common with sometimes less side effects. So thank you so much for your attention. If anyone has any questions, they want to reach me, they can scan this QR code, and then it brings them to a lot of information on prostate cancer that has been curated by the American Urological Association. So thank you so much for the invite.
Sean, thank you so much. That was a very informative presentation. And I want to ask, we have a little bit of some time. Is there anyone that has a question now for Dr.? Okay. Yeah. Okay, great. Phil, go ahead.
Yeah, that's what. So one of the things when I was looking at your recommendations around the age of testing, one of the things that I've learned at dealing with this is that African Americans have a very different experience than any other race with this particular cancer. It's more severe. It grows quicker. Some folks that I've talked to would say, if it's in the family, you might want to start, seriously taking PSA testing at 40. Thoughts or comments?
Yeah, I think 40 is the earliest, regardless of, very strong family history. We really try not to put, patients in their 30s through prostate cancer screening. There's been some autopsy studies showing that, you can find prostate cancer in their 20s, but it may not be clinically significant. But I agree with you that if someone has a very strong family history, what I like to do for those particular patients is I like them to see a genetic oncologist. So these are physicians that specialize in looking for, particularly abnormal genes, like BRCA1, BRCA2 mutation, because if they really do have that strong family history, then I think that there are a variety of genes that we should know, exist in that particular patient, and even important for their family members. And then if they go on to have one of these genes, then certainly our ears are perked up, and these are patients that will pay extremely close attention to. I think that getting a baseline PSA at the age of 40 is very reasonable. I think we really need to simplify our message to primary care providers, because I think that there's some emerging data that most patients will have a PSA under 1.5 at that age group. And then those are patients that we probably don't have to worry about too much. If initial PSA is over 1.5, then those are the patients that we would like to see early as a urologist, to really, go over the counseling. Are they a candidate for some of these early biomarkers?
And I agree with Dr. Wason that it's important at least to start conversation with a physician at the age of 40 for Black men, particularly for men with family history. And for example, National Comprehensive Cancer Network that consists of 28 leading cancer hospitals and leading experts, their Committee on Early Detection actually recommend to start screening for Black men starting at the age of 40. But the critical data point is PSA screening at the age of 45, as Dr. Wason pointed out. There is a rapidly growing evidence that this first reading of PSA screening at the age of 45 is critically important to determine individual risk of prostate cancer. And this determines how frequently PSA screening will be done. So this first reading of PSA actually prevents unnecessary screening and unnecessary diagnosis by about 40%.
Any other questions for Dr. Wason?
Yeah, I have one. This computer's driving me crazy, but your presentation was very good. And it's right on. And there's no reflection against you. But I'm a nurse and you're a doctor. So I'm listening to your presentation and I'm trying to figure out what happens to the patient afterwards. Is there any psychosocial backup or support for this individual?
So just thank you for your comments, Ronald. And so after the patient's been diagnosed with prostate cancer?
Or his surgery, or when he gets ready to go home, or whatever. And believe me, it's nothing against you. I've worked with doctors for years, but
Yeah.
when the patient's gone, and someone has to be responsible for the patient. And I don't know if you have a nurse in your office, usually it's a nurse or a social worker or somebody. So I'm just wondering.
Yeah, I think that that's a phenomenal question, and I think it's something that we don't focus on all the time. I think that there's a lot of support networks out there. So I think first one is how's your family feeling about this? Are they coming to your appointments? Do you know anyone with prostate cancer that has been through this particular treatment before? And then, I try to connect men with some local support groups, and I've kind of given, talks at some of the groups like the Man-to-Man Prostate Cancer, what to expect afterwards. I think I think in this particular area, there are phenomenal cancer centers that have a lot of resources, clinical nurse navigators that are available. Especially, if transportation is an issue, costs are an issue. And I think that, most major cancer centers, will have a lot of support for men, because we realize, number one, this is life-changing for men, and afterwards they're going to be dealing with things that like incontinence and erectile dysfunction, and sometimes we'll send men to physical therapy up front. And so this is patient population that we have very close relationships with, and so we see patients pretty frequently. But I think Dr. Sherm will talk a little bit about the benefits of a nurse navigator. A great question.
Patient navigators, social workers are extremely important in many sense. First of all, AdMeTech Foundation has a list of support groups, and I think the role of support groups can never be underestimated for men before prostate cancer, before treatment, for men with prostate cancer diagnosis, and sometimes support groups are important for men before biopsy, when their screening is abnormal. And the role of patient navigators it's critical when men are struggling, when men are not sure. Patient navigators can help them, at least, or navigator at AdMeTech Foundation can connect men with support groups in their areas, and patient navigators within a clinical system and social workers can help men get psychological assistance if needed. And it's critical because if we look, Ronnie, your question is absolutely critical, because there was a publication about a decade ago that demonstrated increased risk of suicide among men with diagnosis of prostate cancer. And it was a very significant increase in suicide.
Thanks.
So
Phil, with you being a survivor, did you have a support mechanism? Phil?
I'm sorry. There's a group called Finn. I don't know, Ronald, if you ever heard of them. They're out of Dana Harbor. And I was fortunate who knew somebody, and I went in once I knew my biopsy that I actually had it. I joined this support group. And the one thing that I really appreciated from the support group, it included my wife. So we were very prepared for some of the potential side effects that were going to come out. And I ended up doing the brachytherapy, the seed implant. But I would tell you, I would absolutely agree. Support groups, Ronald, are very necessary for folks coming through, because not everybody had a good experience. And part of that support group, we had a doctor attached to it. So it wasn't just guys sitting there talking, we actually had medical advice that we could access as part of that
Okay,
support
good.
group.
So I have a question. My name's Harold Cox.
Yes.
After surgery, my doc continues to do a PSA, and I had the prostate removed. What is he looking for?
Sean, do you want to ask?
Any rise in the PSA. And so I think the
But I
one,
thought but you need the prostate. I thought that gland actually produced the antigen. If that prostate is gone, what is actually going to be rising?
good, I think you answered your question, because once you remove the prostate, the PSA goes 0. It's undetectable. And so there's different sensitivity assays. So you draw blood. As long as the PSA remains undetectable, there's no evidence of prostate cancer. But this is an early test to determine, okay, is there an early rise in the PSA that may suggest that the cancer has come back?
But my question is, I don't have a prostate any longer. So why is my doc still doing a PSA?
Because prostate cancer, when it comes back after treatment, can cause increase in PSA.
So it can still come back where?
It can come back in the location of the prostate, or it can show up even as a distant, as a regional or distant metastasis. Spread. Okay, so a PSA screening after treatment is critical to detect early recurrence of prostate cancer.
Thanks.
Where intervention can be extremely helpful.
And so I had mentioned that the PSMA test, and this is the perfect area. So if you had your prostate cancer removed, the PSA is undetectable, but unfortunately, a couple of years later, the PSA starts to rise again, and we want to know exactly where the prostate cancer has recurred. Is it the lymph nodes of the bone? Is it where the prostate was? Then this area will light up and tell us exactly where that prostate cancer is. And some of those men are candidates then for radiation to that particular area to cure them.
Yeah.
I understand. Thank you.
And yet molecular imaging, PET PSMA that Sean mentioned, costs thousands of dollars. It's an expensive test, so it makes sense to do PSA first, to see if PSA is becoming abnormal before making decision whether or not to proceed with molecular imaging.
Is it PSA that they do they not still look at alkaline phosphatase and all the other things?
I'm so sorry, Ron, can you please repeat?
Do they not still check alkaline phosphatase and things that used to be elevated from PSA?
Not anymore, not anymore. It used to be the case, but not anymore. Any other questions for Dr. Basin?
I was going to add to Harold, even with the procedure I had, one of the things that I was counseled on, that since you didn't get it removed, that you still needed to check your PSA annually. So even though, I've been a survivor since 2006, my annual checkup, I still request a PSA as part of that. And I hold my breath. Because here's the thing, very quickly, when I spoke to the radiologist, I talked about how many had he done and had anybody had a reoccurrence. And he told me, yeah, he said, I had at least one person, he had done close to over 300. He had one person that had a reoccurrence. So that just made me a little vigilant about it.
Yeah, and actually overall a recurrence rate when prostate cancer comes back after treatment, recurrence rate, depending on a surgeon or another physician, to be honest, it is 20 to 30%, if not higher. So 2 to 3 men out of 10 are going to have recurrence of prostate cancer after treatment. Now, this number, if we talked about, let's say, 5 to 10 years ago, it would be 40% recurrence. Right now, with better imaging tools, with better diagnostic tools, recurrence went down to about 20 to 30% roughly, but it's still there. Any other questions for Sean? Okay, great. Katya, with your permission, can we proceed with my presentation?
Okay, yep. I think that's fine. Harold Cox, I just want to introduce Harold, who just asked the last question. He is an Associate Dean for Public Health and an Associate Professor for Community Health at BU, and has been a guest speaker with us for the last couple of years. He is also a prostate cancer survivor. So, Harold, thank you again for joining us, and thank you for your question. Do you have anything you'd like to add, or should we go right to Dr. Stern? Did you have something you want to say?
I would only say that I came in toward the beginning of your presentation, Dr. Watson, and appreciate it very much. My experience was now maybe 12 or 14 years ago, so I don't know what that experience might be now if I were to have prostate cancer. Certainly, um, some of the investigatory skills and tools that you have now were not available at that time. I actually ended up having 3 biopsies over a period of about 2 years. So a lot of things have changed. But I would only say how important it is just to go to docs, to go to a doc on a regular basis. And perhaps the most important thing I would say is to have an honest conversation. I appreciate what you said about the importance of having a collaborative conversation with the docs, that it's something that you and the doc do, because at the time that I did this, I got actually very good care, but at one point I was going to a lot of docs and trying to make decisions about what I was going to do, and then they said, so what do you want to do? I don't know. I was kind of confused mostly by that question of what is it that I wanted to do. So it's but nonetheless, I was very fortunate to have good support. Ronald, I think the question that you asked about support that comes after is critically important, because in dealing with issues around incontinence and erectile dysfunction and what that means in your life, it becomes really important. If there's anything that I would have actually asked my doctor to do more of, and I really appreciate what he did do, but if there was anything that I would ask him to do if I would do this again, is to help me understand a little more about what was going to happen after this was all over, and to be a little clearer. He did explain, and he did have a nurse practitioner who helped to follow up with me, and I was grateful for that. But I needed to have a little bit a better understanding about what was going to happen before it happened. So thanks for that presentation. It was really useful to actually hear that. I'm always appreciative for being updated about what's happening in the field.
Thank you, Harold. Thank you. Now we're going to hear from Dr. Stern.
Thank you so much. And Professor Cox, I would like to, after my presentation, I would like you to please comment on the importance of the support system that we are building for prostate cancer equity program.
Be happy to.
What it would have been like for you to go through your experience if you had this resource available to you?
I'll be happy to do that after you speak.
Absolutely. It would be really appreciated. So Emma, we routinely started doing pre-recording of all my presentations for in virtual space to avoid technical problems. Emma, please. My name is Faina Stern. I'm a physician and founder of the AdMeTech Foundation. I'd like to express my gratitude to Katya and Reddick for her partnership in this event. AdMeTech Foundation provides leadership for the groundbreaking programs in prostate cancer at the state, national, and international levels. Our programs have been transforming patient care for everyone and reducing health disparities in Black men. Dr. Wason outlined recent advances in screening, diagnosis, and treatment of prostate cancer. The goal of my talk is to describe our prostate cancer equity program, launched with the goal to bring these advances in patient care to every man in Massachusetts and eliminate health disparities. Prostate cancer equity program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, and research. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. This program was initiated since 2009 in collaboration with multiple organizations and has three components: public awareness, medical education, and research. Public awareness and education, we had reached well over 36,000 men since January 2020. While we are dealing with COVID pandemic, prostate cancer cannot wait. And yet many men avoid visits to their doctors out of understandable concern of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life and even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits, telehealth, ongoing in-person care, doctor's appointments and testing, and medical procedures such as biopsies and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men in our country. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only about 28% of men remain alive during the same time. In prostate cancer, screening with blood tests called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors, such as Black heritage, family history of prostate cancer, particularly in a brother or father, and increasing age, 50 and older. You can ensure early detection. During annual visit, ask your doctor about PSA blood test and digital rectal exam. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors I just mentioned. Before screening, it is important to avoid exercise or sex, which may impact your testing results for 1 week. After screening, you need to ask your doctor if your test is normal or if you need to see a prostate cancer expert for further evaluation. For public awareness and education, our messaging centered on the importance of screening and early detection, critical for saving lives. Since 2015, we focused on Plymouth County, which led the state in Black mortality. At that time, Plymouth County had higher than state average disparities. Indeed, Black men were 2.5 times more likely to die compared to white men in Plymouth County. By 2021, we saw over 55% reduction in disparities in death rate between Black and white men, reaching near parity. At this time, Black men are only 1.2 times more likely to die compared to white men in Plymouth County. This is a disparity that is much lower compared to statewide disparity in prostate cancer. During the same time, between 2015 and 2021, there was no reduction in disparities in death rate of prostate cancer at the state level. The centerpiece of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest 6th annual conference took place this year between September 22nd and 24th. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices. This educational event showed rapid advances in patient care. In screening, our summit supports clinical guidelines for early detection recommended by the National Comprehensive Cancer Network, consisting of over 28 cancer hospitals and their leading experts. As mentioned, high-risk men, including men with a Black heritage, or family history of prostate cancer, are recommended to start screening at the age of 40. Average risk men should start PSA screening at the age of 45. This first or baseline PSA result in younger men has emerged as one of the most important indicators for developing lethal prostate cancer long-term over 10 years. In diagnostics, we have seen emergence of very accurate non-invasive tools such as blood, urine, and saliva analysis for molecular and genetic markers, and advanced imaging, including ultrasound, MRI, and molecular imaging. These non-invasive diagnostics, highlighting the importance of PSA screening, shifted past concerns about screening for prostate cancer into a dustbin of history. For example, these diagnostics can determine which individual man has an increased risk of life-threatening, rapidly progressing prostate cancer, improve early detection, critical for saving lives, reduce unnecessary procedures such as biopsy and treatment, and optimize selection of personalized care for each man, including careful observation or active surveillance, minimally invasive interventions, or immediate radical treatment. High-risk individuals, including Black men, carry higher risk of both mortality, dying of prostate cancer, and unnecessary procedures. Consequently, it is critical for them to have access to precision diagnostics that determine for each individual man if he should or should not have invasive biopsy or treatment, and what options in clinical care are best for him. Unfortunately, in Massachusetts, Black men are less likely to have precision diagnostics, such as advanced imaging, MRI, or molecular imaging, or genetic testing, or undergo life-saving treatment compared to white men. Prior to undergoing invasive biopsy or treatment, it is important for each man to discuss with his doctor if any testing is available to determine if these procedures are actually needed, and if yes, what kind of options would work best for him. For example, in this slide, magnetic resonance imaging, or MRI, shows prostate cancer lesions and guides biopsy needles with precision. AdMeTech has led research development and large-scale clinical implementation of prostate MRI since 1998. Our summit highlighted the importance of MRI in Black men who are more likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard blind biopsies performed without accurate imaging. In men with prostate cancer, there are two pillars of the current diagnostics, MRI and genetics. While MRI shows cancer location and local spread or stage, genetic analysis of cancer tissue reveals underlying biology and probability of progression. Emerging data indicate the importance of genetic testing for many high-risk men, Black men in particular, for selecting the most effective treatment. With this precision diagnostics, we can now accurately determine if each individual man has a slow-growing, what we call harmless prostate cancer, or needs a careful observation, or an aggressive version of prostate cancer requiring immediate life-saving treatment. More recently, molecular imaging has been shown to play an important role in staging of prostate cancer, including presence of metastatic spread and detecting return of prostate cancer after treatment. For example, PSMA molecular imaging has been approved by FDA within the last year and become available at the Dana-Farber Cancer Institute since August 2021. On the left, right here, we can see a traditional bone scale showing no metastatic spread. However, on the right, in the same patient, molecular imaging demonstrates extensive metastasis. This information is important for selecting appropriate and effective treatment. We are proud to have led research and development of molecular imaging since 2001, based on the evidence coming from military medicine, from veteran administration. Our summit concluded that equal access to high quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high quality personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and NAACP New England Area Conference with their multiple branches located across the state. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. Any Massachusetts man age 40 and older can participate. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsy, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how a physician like me takes care of my family and friends. This process consists of 3 components. 1, AdMeTech Foundation's coordinator collects basic information and matches individual patients' need with the appropriate state's experts. A clinical organization designates a patient navigator who works with multiple schedulers to expedite a medical visit. If an expert recommends any next steps, for example, additional testing or treatment, AdMeTech's coordinator and patient navigator work with men on the appropriate follow-up. To ensure successful implementation of this program, AdMeTech has created a network of leading state experts committed to eliminating health disparities, develop an effective process for patient care and follow-up, as mentioned, recruited community coordinators in high-risk areas who mobilized a network of over 100 program ambassadors, community, organization, and church leaders, held multiple focus groups to develop program materials. Our current goal is to identify and mobilize appropriate organizations and individuals so that men, their primary doctors and caregivers, have access to this program. Trisha Kinney, a member of the AdMeTech Foundation staff, serves as a statewide coordinator for the Prostate Cancer Equity Program. If you have any questions or need assistance, please contact Trisha by phone, 617-523-3535, or by email, coordinator@admetechfoundation.org. Thank you for your attention.
Thank you, Dr. Stern. It is.
Oh, so sorry. Professor Cox, do you want to comment on the role of patient navigators, the role of support system that we are creating through the Prostate Cancer Equity Program.
So first, Dr. Stern, congratulations on the work that you're doing. I think that it's critically important to provide this kind of service and resource. Here's what I would say about navigators. I think that when people get diagnosed with anything, it's scary. Having the slightest idea what's about to happen to you, and there are a number of supports that people need. I think that I can just give only two really short stories. It was important for me as I was going through my process of having someone who went with me to my appointments, because I heard everything the doc said, or I thought I heard, and when I walked out of the room, I didn't remember any of it. So it was important to actually have someone who could say, here's what was actually said. The second thing is, when I went in for surgery, I had this brilliant idea that I was going to go in, I was going to have surgery, I'm going to have a little meal, I was going to go back home, everything was going to be all right. I had some friends, fortunately, who had a different idea about what was going to happen to me, and they kind of whisked me away and took care of me for a period of time while I was recuperating. It was important to actually have someone who could say, look, here's what's going on. And so I think having navigators and having other support systems provide a few things. One, they provide information, because there's lots of information. All the information that Dr. Watson gave is critically important, but I must tell you, it's not just something that sits on the regular person's I mean, it's not something we all know about a lot. So it's important to get information. It's important to get support, because when you go through something like this, it's important to have somebody who can say, here, let me support you. And I think as Phil talked about the Fin support group and some other initiatives, those are critically important. And then lastly, encouragement to continue to stay healthy and to do the things you need to do, watch your diet, etc. So navigators are important in providing a number of those kinds of resources to help people through this very critical and important time in their lives.
Thank you so much, Professor Cox. Ron, you are in charge of patient education, essentially, for Prostate Cancer Equity Program. Do you, with your experience of over 40 years, clinical experience, can you provide your perspective of why you got interested and became a part of our Prostate Cancer Equity Program?
To be quite honest, I guess it's kind of prejudice, but I think nurses have a different perspective when it comes to talking to the patients. And I think they can bring it from the very medical point of view and right down to earth and make them feel much more comfortable. And I think that a lot of patients sometimes feel more comfortable talking to a nurse or social worker than they do to the doctor. They might like their doctor and everything, but the chances are when they leave, they're not going to see the doctor. So I always, and I've done this for years, I've always made myself available to the patient. And this may sound crazy, but I still use this philosophy. The only difference between me and the patient is that they're the patient, because it could be me. And if it was me, I'd want someone like me to be there. So, I mean, I used to work in pre-admission, and I would see the patients in pre-admission, and it wasn't my responsibility to see them after the surgery. But I knew what they had told me in pre-admission, so I would go upstairs and see them after the surgery. And I don't know what difference it made to them, but it made a difference to me. It made a difference that I just felt like it gave continuity. And it might be a week later, they go, hey, that guy came upstairs to see me. Yeah. And even when I worked in radiology, I would see the patients, but when you sent the patient back upstairs, the nurses on the floor didn't know who the nurse was in radiology. But the patient, when they got up there, they would talk about the nurse in radiology, so then they called. So I just believe in communication with the patients. I think I was put here for a reason, and I know it sounds crazy, but I think I was put here to care for people, let it be my family, the patient, my jobs, everything, and I still do it. So,
thank you so much, Ron. Krisha, do you want to comment what it is like for you to interview people, to take care of them, essentially, and to make sure that they're moving in the right way through the various clinical healthcare systems?
Yeah, absolutely. Just to quickly introduce myself, I'm Trisha, and I am the coordinator of the Prostate Cancer Equity Program. So essentially, if you contacted AdMeTech to inquire about the program, I would be your first contact person. The reason I think that this program is really important is because it acknowledges the difficulties that exist within healthcare systems, whether it comes to finding providers or even navigating conversations with providers or navigating insurance. I think the Prostate Cancer Equity Program really strives to support patients within that process. Within my experience with the PCE program, I've had several conversations with patients, and they've talked about what they're looking for. And a lot of the patients that we receive, they struggle with insurance, and they don't know who to contact, and they're just seeking support through that process. I think overall, for me, it's been very fulfilling, especially to be a source of support for these patients and to also incorporate patient advocacy within the process, because a lot of the patients also are looking for quicker appointments sometimes when they're scheduled, because it takes a while to schedule appointments with providers sometimes. A lot of my role within the program also involves some patient advocacy, which is also very fulfilling. But yeah, that has mostly been my experience. So I really would encourage everyone watching our event today to contact us, whether you just want to learn about the program or you're looking for a second opinion. The program is here for you.
Thank you so much, Trisha.
Dr. Wason put into the chat some material for people to look at. I was just jotting it down. Do you want to talk a little bit about it, Dr. Wason?
Sure. And I think, we know that there's a lot of information. There's a lot of information for us to know. It changes all the time. We want to arm patients with as much resources as possible. And so what I'll do as a patient comes in for a prostate cancer consult, I will text them this particular link for evidence-based resources for, patients newly diagnosed with prostate cancer. And, this is a phenomenal resource, not only for prostate cancer, but other urologic diseases as well, that is evidence-based, has a lot of information, podcasts, and it's great if patients can get a hold of this information before they come to the office, so they come armed with questions, because we know that they're going to have questions before and afterwards. And just unfortunately, in the nature of today's sort of office visit, we don't have the time to go over everything, but we recognize that patients have these questions, and we want to give them as much information as possible.
Can I make just one comment? I appreciate the information that you gave. Something that was very helpful to me when I went through this, my doc also gave me a very lengthy document that he'd written about what I could expect after. I needed more information, but it was a very useful guide to have of understanding some of the things it was going to mean to be wearing a catheter, and et cetera. So that this goes back to the question that Ronald asked a little earlier about how we support people post treatment, things like surgery, et cetera. It was very important to get that information. It's so important to be able to just say how important it is to be able to tell people about what to expect when they're doing their treatment and once treatment may be over.
If I were to turn it into what patients can do, it's really important to ask your doctor what to expect after treatment. But in addition, somebody like Ron is available through Prostate Cancer Equity Program to sort of explain this to men in a great detail. Phil, I apologize, I interrupted you.
Oh, no. I was just going to say there are two pieces. The first part is, Dr. Wason, I just want to thank you, because at the point you get diagnosed, most people are they're frozen. You got cancer, and what do you do with it? And I'm not saying this against all urologists, but you have this thing called the gold standard. And the person starts in saying, well, surgery is the gold standard. And if I had not had some background information, I would have gone with surgery because I'm not a doctor. He's telling me surgery to go say. And about 10 minutes into the conversation of me asking him questions, he said, let me suggest I schedule an appointment with a radiologist. But without me having some information and some understanding, I would have never gotten there. I would have been into surgery easily, not even aware of all the other techniques, that you laid out.
Yeah.
You touched on a great point. We're surgeons, and we're trained to kind of cut, and a chance to cut is a chance to cure. Not everyone is a candidate for surgery, and I think that really our goal is to give you as much information as possible. I think patients need to arm themselves, their families need to arm themselves with as much information, so you can come with those questions. And really, our goal is to give you that information and match the patient up with the treatment that is right for them based on their goals of care. And everyone is different, and I think that that's really our role as a urologist. But you touched on a great point, and we want to make sure that patients have a great experience, coming through surgery, and so we recognize that happiness is important to patients, and we don't want somebody to really regret their decision on which path that they went in the prostate cancer world. And so we really try to give you as much information as possible.
Absolutely. And also right now, let's say at UMass, at Magellan Brigham, it is almost becoming a standard practice. When men is diagnosed with prostate cancer, there is a panel of specialists, radiologists, radiation oncologists, urologists, and each can provide patient information from his or her perspective. Okay, so patient can make choices, but very frequently, as Professor Cox pointed out, it can become overwhelming. And the presence of people who can help you process this information, such as Ron or myself, within Prostate Cancer Equity Program, I hope we will be able to help men by helping them process information, or at least to formulate questions to their providers.
Phil.
No, I was just going to say my last quick comment is I wanted to build on something you said, Harold, about the importance of having some sort of support after the procedure. And let me tell you some of the things that were very helpful. They actually brought in speakers on diets. They brought in speakers on erection dysfunction. If you are having this difficulty, here are some strategies, some options that you can look at. And that made a difference for a lot of people who were going through some very difficult side effects. And when you're in your 50s, you still plan to be sexually active. And so when that gets challenged, that is traumatic in a lot of ways. So just know that support is key.
Yeah.
I'm sorry, Harold, go ahead.
Phil,
Yeah.
there's so many different kinds of support that people need. And one of those, Ron and Dr. Stern, and you may have actually already done this, but if you have not, I would suggest that you do. You said you were going to help people to decide, to think about what are the questions. It might be useful for you to actually put together just a one-pager that says, here are the questions that you ought to ask. So, because I think people, it's important for people to ask questions, but I think many times you don't know what to ask. So just something that actually identifies. So here's the list of stuff. Here are the 10 most important questions, or the 15, or whatever it is, number of questions that you have. I realize that docs don't have lots of time. And I also realize that there is this attitude that we have. We are trained not to ask doctors questions. Doctors are trained not to want us to ask questions. And it's a little frustrating. So I do think that having those questions and being able to actually say, here, take this to your doc and ask these questions will be really important, and important resource for people who are having this problem?
Yeah, and it can be generic. It can be generic list of questions, and
Yeah,
then
sure.
it can be modified based on a specific situation that man is facing. Absolutely,
know,
it's a great idea, and I think we should do it.
I know you're going to think I'm crazy when I say this. No, I'm not crazy. But the doctors I used to work with, I said, there's a lot of assumptions that we make. Number one, we assume everybody can read. And we do. We assume everybody can read. There are a lot of people out there who can't. So I would always make myself available to talk with somebody and stress with them if they didn't feel comfortable or didn't understand what was being given to them. Have somebody call me and they could be on the phone so we could all talk about the same thing together. Because I can tell you, working at a medical practice, there were a lot of people, the doctors would hand them a piece of paper, give them their shot or whatever, and they left. And then I get a phone call and I said, I don't know what he's talking about. I have no idea what he's talking about. And we do still assume that people can read. Another thing we assume, people write things and they think people can read cursive and they can't because they don't teach it anymore. People don't know how to read it. So there are a lot of things that go on out there that we don't think about because we still know how to do it. So
Ron, can we clone you?
oh, sure. Go ahead. No, you can't clone me. I know, as my mother told me, I was one of a kind. You know what? It worked in my favor. I know it did. Kathy can vouch for it.
Yes, I can.
Yeah.
See, Harold, it's not just you. There are many. And Phil, this is a team. I love it. I love it.
I just wrote in the chat, Ronald, you are a caring individual. You really are. I wish
He really is.
thanks.
He really
I
is.
agree with Harold. We should clone somebody who actually gives about
He
the
really
patient.
Well, I'm glad, and I just met you. So, I mean, that's really kind of, not to get off the subject, but I just have to tell you that my aunt died last week. We were at the funeral, and it was a family funeral, and my cousin got up and he said, I would be an idiot if I stood here and didn't thank Ronnie, because everything that comes up, we go to Ronnie first before we go to the doctor, so he can give us the information. And it goes from my neighbors to my family. So whatever I was blessed with, I'm glad I have it. But I do like taking care of patients. And the reason why I'm a nurse is because I have patients.
Ronnie is authentic. He is exactly as he says he is.
And the way our program works, people come to Trisha, and Trisha connects people with Ron.
So
Trisha and I have been connecting all week. She's probably
there you go.
sick of hearing from me.
He's an excellent resource, Trisha. Excellent.
Yeah, we actually just hired Ron a few weeks ago, but it feels like he's been with us for a while.
Trisha, what's my motto? Surfer to the higher power, right? When you have a problem, you can't do it, just give me a call. I'm here. I feel like we're all here for the same reason. So
Yeah, we are.
Back to you, Tatiana.
Well, it's 8:30. This has been a wonderful educational event tonight. We've learned new things. We've met some new people. Everyone that was invited, for whatever reason, wasn't able to attend. I'm getting emails from people, sorry, I can't attend. Can you send me some information? It's just absolutely wonderful. And I'm very proud to work with AdMeTech and to work with all of you in this effort. We are planning an event coming up in September for Prostate Cancer Month. There'll be more information coming out about that. I'm sure you'll hear about it. But until then, thank you so much. Stay safe. And it's just been a wonderful event. Thank you.
I'm gonna go roller skating.
Thank you so much. Thank you so much.
Not to wait, so we have to show them the background. I'm not getting on the skates.
Sean, we'll
Take
meet you
care,
down the roller
everybody.
skating rink, all right?
Yeah. I'll be there tomorrow, 2 to 5.
2 to 5? Oh, okay. All
He
right.
may show up. Right, he may
Yeah.
show up. All right. Take care, everyone. Thank you.
All right. Thank you. Good night.
Good discussion. Thank you, everybody.
Night.